Good morning, everyone. Welcome to my podcast entitled Self-Stigma and Bipolar Disorder Around the World. The Be There movement is described in detail on my website. It's the first podcast I produced. And the fact that you're listening to this podcast means that you're part of the movement. What does this movement entail based on the visual? It starts with purchasing my book, which you can buy on Amazon, an ebook, and the audiobook will be loaded in the next few days. It's fully completed, and it will be sold on my website. Wines for Humanity is a company that donates 10% of its proceeds to the charity of your choice. We have already done that. We've produced or hosted several wine tasting events. At these events, people can buy raffle tickets, and that money goes to my sister's foundation. And the tickets are drawn, and the people who win, and we usually give away 3 to 5 baskets, which contain 2 wonderful bottles of wine, a white and a red. And all the wines are curated from Europe. The owner of the company, Anton Steinhardt, is German, and he founded the company about 20 years ago, and the company is growing. Their wines are delicious. My sister's foundation is doing business as it's a set up in the state of Florida, and I've made my first donation to the Falk Center for Counseling in Boca Raton, Florida. We also are tied in with, so to speak, bipolar awareness, and always will be, because we need the world to be more aware of bipolar disorder and treat this disorder as well as other mental illnesses, like the world does when someone finds out that you have cancer, or you're diabetic, or you had a heart attack and you're recovering. We don't treat people who suffer from a mental illness the same way. And you'll learn about that in this presentation. This presentation comes from Sophie Fabre, Helene Richard Lupriel, and they are on the staff of Geneva University Hospital and the Department of Psychiatry at the University of Geneva. It's a systematic review and evidence synthesis. And they did a review of all the research that's been published around the world in different countries about bipolar disorder and other illnesses, and they categorize them as such in the research. I want you to know that all citations in the slides are cited in the author's journal article, which is standard and customary and required at the very end of every scholarly journal article. The writers must produce all of the references they cited in their paper. So I have some of the citations, but I don't have to cite all of them or the page numbers, because I am borrowing this information from these 2 writers. The background on self-stigmatization. What happens is the person's aware of societal stereotypes about mental illness, and they may say something like this: I know that part of society thinks that the mentally ill are dangerous and incapable of doing anything. And then comes the deliberate self-harm, which means that the patient agrees with that stereotype and may think, a person at work said that I was incompetent because of my illness. I believe he was right. I don't feel capable of working. My sister worked for about 12 years with bipolar disorder. She was on a mild tranquilizer and taking lithium. She was working in different hospitals. Believe it or not, she worked with psychiatric patients. And she finally decided, I can no longer work anymore. I believe she might have been cited for some of her bizarre behavior, because even though you are on your medication, you can still engage in bizarre behavior. And I cover that in my book. but she was no longer capable of working in her field, which was extremely sad. Background information. Self-stigma arises when the patient avoids situations due to their mental illness. What I just noted, my sister, I'm not going to be able to work anymore. I'm useless and good for nothing. Why would I apply for a better job? My sister did. She decided I'm going to try to work again, and she also applied to get into a PhD program because I think she always wanted her PhD. She had a master's in social work, but she, I think, felt that if she got a PhD, that would help her and save her. Self-stigmatization alters the constructed identity and limits the hoped for identity. You know, a person who's a student who hopes to become somebody someday. The self as a parent. Oh my God, I'm the parent of a person suffering from this illness, like my parents were. The worker, the spouse, etc. These are abbreviations that are covered in the research, and I reference some of these in the presentation. So if you see these, you will know what we're talking about. MDD, for example, major depressive disorder. ISMI is the internalized stigma of mental illness scale, and we'll go over that a little bit. This is very, very interesting. The research was conducted in many countries around the world, and the article includes a lot of really interesting tables that compiles all the different research in different categories of how they looked at the research. And this is really significant because this is global. It's a worldwide problem. 13 European countries, there were 578 people in this sample who were suffering from bipolar disorder. Six more European countries, 796 people with major depressive disorder and 89 with bipolar disorder. Now, these sample sizes may not, seem to be a lot, but they're sample sizes nonetheless, and they're relatively large in terms of the people who filled out questionnaires, and that's where we get our information from. The larger the sample is, and the more people that respond to the survey and complete it, the more data we're going to have to report. So this is important. We've got Turkey, we've got Korea, we've got Taiwan. And also to continue, India, 1,403 individuals, including 344 with bipolar disorder. Okay, and they give you the percentages here. Another on India, Saudi Arabia, 93 individuals, including 50 with bipolar disorder. This is interesting. The self-stigma scores did not differ significantly between the bipolar disorder and the major depressive disorder groups. But there was a negative impact of compulsory hospitalization. We have Ethiopia also, and China. China, 453 individuals, including 39 with bipolar disorder. Moderate and severe self-stigma observed in 94.7% of the participants. And the research is ongoing as I speak. What happens with research, conduct this research, you use the instrument and other instruments, and then you add on to what's already known about the topic you're writing about, and you may confirm or refute the research because you have to do your hypotheses. But the beauty of all this is we're continuing to add research to what we already know. And this is important for helping people with bipolar disorder as well as other illnesses studied in these hospitals. Negative consequences of somebody suffering from bipolar disorder, as well as other illnesses. Learned helplessness, okay? This is when you're trying to build your identity or you have an identity crisis. What's going to happen to me? My poor sister, sure, her identity was to be a psychiatric social work. And then her whole life was destroyed because of the illness. The why try attitude, poor social relations because of the illness, low self-esteem and anxiety, and hopelessness. But one of the things you must remember, if you're suffering from the disorder, you're a family member, you're a caregiver, or you're just interested, there is hope. There is always hope for tomorrow. Better medications have come out in the market, and we're learning more and more about this illness. To continue, self-stigma can influence people in their personal or professional choices, to have children or not have children, applying for jobs or accepting positions of responsibility. More severe symptoms. And self-stigma also has a negative impact on the course of different mental illnesses, as it is correlated with more severe symptoms, more relapses, more frequent hospitalizations in persons with depression or anxiety or bipolar disorder. It also negatively affects treatment-seeking behavior. My sister was always seeking medication, and she was a prescription drug abuser. She found, as I describe it, that she liked painkillers, but I know she was suffering later on in life in pain because she was starting to get arthritis and what have you. But she found that she liked painkillers, and she was always seeking painkillers. But the hospitals and places she stayed knew that. They picked up on it right away. And so they controlled her medication for the last 15 or 20 so years of her life. Although a good therapeutic alliance is correlated with less severe symptoms, it is insufficient to improve the experience of self-stigma. To continue with negative consequences. In 2013, Hawk et al. Showed how stigma toward persons with bipolar disorder and their families was insidious and occurred in various settings. The social environment, work, in healthcare settings. The stigma was also related to loss of social support, higher symptom levels, and lower quality of life. I can tell you that I've been to many psychiatric hospitals over the year where I visited my sister in different states and in Florida, and I could pick up on the body movement, body language, and eye contact, and attitudes of some of the caregivers working in the psych wards. Okay, they were CNAs, some of them were nurses, and of course they have high stress levels because many times they're understaffed. But I could just pick up on the body language, and some of them just looked down on the people. They didn't like their job, and they weren't always the nicest in terms of their dealing with people skills. But there wasn't anything I could do with it except say something, which a few times I did. To continue, schizophrenia is more stigmatized than bipolar disorder, and bipolar disorder is less stigmatized than anxiety. I'm highlighting these, you see. Self-stigma in bipolar disorder was correlated with poor self-esteem, reduced community participation, and low quality of life. What's wonderful about some of these community centers and places where people can go for counseling is they can meet with other people in similar situations and at least have some participation with members of the community. Another review established that self-stigma was associated with poor clinical and functional outcomes in persons with serious mental illness. Psychometric tools. Okay, we learned about the internalized stigma of mental illness scale early on. There's another one called the self-stigma of mental illness scale. And of course, these scales are developed by researchers, and they have to pilot test these scales, and they collect the data, and they continue to add to the database and make it more robust. The ISMA consists of 29 items in 5 subscales. So if you're trying to tap into alienation, there are 6 items that are attempting to tap into the extent to which someone feels alienated. And then the self-stereotype endorsement has 7 items, which reflects agreement with negative stereotypes of mental illness. Then you have the discrimination experience with 5 items, social withdrawal, 6 items. This is interesting, which reflects avoidance of others because of mental illness. Stigma resistance, 5 items, which inquires into the participant's perceived ability to deflect stigma. To continue, authors included studies published in academic journals which were either controlled trials with a control group, uncontrolled pre- and post-intervention studies without a control group. One of the things they wanted to have was longitudinal studies, but the problem with the longitudinal study is you have to study it over a period of years and to see what changes took place. and from the beginning. But problem with the longitudinal study, who's going to do the study? Are the same people going to be there? And there are other problems with the longitudinal study, but those are really great studies, particularly if you have most of the same sample. Then there's cross-sectional studies, qualitative studies, wherein you do more written versus quants. You don't have to do statistical analysis. You can do open-ended interviews and group interviews where you're documenting what people say. And then there's the pilot studies where, we're going to pilot this and see what the results are, and then continue on if the results were favorable. And these all included people living with bipolar disorder. And the search strategy is important because you don't want to publish an article when you don't have, good articles. And the search strategy produced an initial total of 265 titles / abstract. An abstract is a summary of the research, which is usually at the beginning part of a journal article. 109 abstracts were excluded because they appeared in more than one database. And 85 full text articles met the criteria, and 66 of which were covered in the question of self-stigma and bipolar disorder. Now you can say, oh, they're not that many studies. This is, what use is this? Well, it's very useful because these studies take a long time to get published, and they are not accepted into a scholarly journal article. They have to be refereed and they have to be reviewed by experts, et cetera, to make sure that, there was no faking of the data and so forth, and to check the integrity of the data and the writing and so forth. Medication stigma, that's an issue. It can be assessed by 3 dimensions: the disclosure that you're on medication, the shame you feel that you're on taking medication, feeling judged, and that's why a lot of people won't go on medication. I know people that know they need to go get help. I'm not going on medication, okay? I'm not going to a doctor. I'm not going on medication. I want to be drug-free. Those people are missing out because there are so many really good drugs on the market. Yes, we know the pharmaceutical industry is making millions, if not billions of dollars. And, there are issues with that, of course. And they use a lot of the money for research, but so many of the drugs do help people. The adverse effects of psychotropic drugs can also have an impact on self-stigma, especially with 2 or more medication side effects, which we're going to get into. Tardive dyskinesia is induced by antipsychotic drug or self-stigmatization, especially on the social withdrawal spectrum, which in turn can lead to a diminished quality of life. And I know people that have tardive dyskinesia. My sister had a little bit of that. And so many of the people where she was living had tardive dyskinesia. And it's a neurological disorder that usually develops after long-term use of certain medications, especially psychotropic drugs. What happens? Well, it causes involuntary repetitive movements. And so many of the drugs are advertised on TV, and I've seen ads on TV that will help control tardive dyskinesia. People grimacing, lip smacking, their tongue is hanging out, they have mouth and jaw movements, rapid blinking of the eyes. And why does it occur? Because it's linked to long-term blockade of the dopamine receptors in the brain. Now, remember, everybody, if you don't already know this, a mental illness is a chemical imbalance of the brain, okay? Let's treat it as such. Somebody who is mentally ill can't help it. They have a chemical imbalance of the brain. But that's not okay with mental illness. But it's okay with other people that have other illnesses. Let's make it okay for people who are suffering from mental illness and start treating them differently and viewing them differently and having more compassion for these people. They can't help it. It's a brain disorder. 13 bipolar disorder studies, okay? Self-stigma and recovery. investigated the effects of self-stigma on recovery, 2011 to 2021. And these studies show that a high level of self-stigma was associated with poor recovery. So let's just assume you know people who are suffering from a mental illness, you're a caregiver, you're a family member, you're a student at school. Don't make fun of the person, don't laugh at the person, don't gossip about the person and make them feel uncomfortable if you're in a school setting. Even though you got privacy laws and you have HIPAA and the person doesn't have to disclose to people that they're mentally ill, people will pick up on it. And the worse you treat them, the worse it is for the individual to try to recover and have a normal life or a somewhat normal life. Also, for clinical recovery and substance abuse problems. Other negative stereotypes, 28% of people think individuals living with bipolar disorder are violent or dangerous, compared with 54% for schizophrenia. Okay, think about all the people you've learned about on TV, on the news media, however you get your news, who went and shot somebody or were taped engaging in some sort of violent act. There's a strong possibility, in my opinion, that they're suffering from some mental illness that has not been treated. And 32% of people think individuals living with bipolar disorder have behavioral problems, compared with 86% for schizophrenia. Speaking of the media, over the last 2 decades, the media coverage has been displayed through TV programs, TV series, and celebrity disclosures. My last podcast, I mentioned celebrities and famous people in history who suffered from bipolar disorder. But bipolar disorder has been associated with literacy and creativity and sometimes a glamorous image. And thus, public awareness of bipolar disorder has substantially increased. And this was as of 2018, but it's continuing to increase more awareness of mental illnesses just through the media. Regarding stereotypes, there are positive stereotypes: spirituality, empathy, realism, and resilience. My sister had great resilience. Creativity, intelligence. My sister was brilliant. She had almost perfect scores on all her undergraduate and graduate admission tests. These positive data about the perceptions concerning bipolar disorder may help decrease self-stigma and people with this disease. Again, there is hope. They do demonstrate positive aspects. My sister was so generous, even though she always wanted money from me, but she would give things away to people. People liked her. She was friendly. Many hospitals she was at, the people would tell me she is really good. She runs the group. She's really nice. She really tries hard. What a tragedy. I'm so glad I wrote the book about my sister. More on the studies. Again, to recap, low self-esteem, low self-efficacy. Self-efficacy has to do with, let's take a training situation. If the person has low self-efficacy, they will feel that I don't think I'm going to learn anything from the training, or I'm not going to be able to participate in the training. And so that could adversely affect, their participation in the training and finishing the program and so forth. Hopelessness. All of these are examples of the negative consequences. So to continue, individuals with bipolar disorder are also described as demonstrating poor adherence and discontinuation of prescribed medications. What happens is that you're taking the medication and you start feeling really good with, let's say, the new medication or the medication you've been on for a couple months, and you say, oh, wow, this is great. I don't need to take this crap anymore. I don't want to put this in my body, and I don't need it anymore. And then they throw the medication away or gum it or spit it out, and then they go back to where they were before. and it may be worse for them. And then they may have an increased demand for mental health services because they're not adhering to the medication. And that increases the service costs. So thank you very much for being here today. And I look forward to having you in another podcast. Goodbye.